Indwelling silicone catheters is routine practice in our NICU since many years. In designing this new device, we have aimed safety with an easy and comfortable technique for the baby. The silicone catheters are preferentially inserted into the umbilical vein. The percutaneous route is used in case of malposition or if the attendant physician is not familiar with the technique and if the umbilical vein is not accessible anymore.
The catheter insertion distance into the umbilical vein is determined by the shoulder umbilicus graph. The abdomen and the umbilical cord are carefully disinfected. The baby is prepared under classical conditions for sterile umbilical catheter insertion. The umbilical cord is secured with a purse string suture near the base of Wharton jelly and cut at 1.5 centimeters. The umbilical vein is identified and prepared for catheterization. The device is prepared on a sterile drape. The kit contains 3 different sizes of introducer, together with the classical silicone catheter and the easy lock connection system. The catheter is connected with the easy lock system and flushed with saline. The introducer is flushed with saline too by introducing the silicone catheter for a few millimeters into the metallic part. The catheter is pushed forward 1 to 2 millimeters ahead of the distal end of the introducer. A hemostat forceps is gently clamped at the proximal end of the introducer and will stop the catheter from moving. The introducer with the silicone catheter in its lumen is now inserted and advanced into the umbilical vein. The hemostat forceps is removed. After the introducer is advanced the appropriate distance, the silicone catheter is pushed forward with a non-toothed forceps and the introducer carefully withdrawn. When the introducer is out of the umbilical vein, the catheter is disconnected from the easy lock infusion system. The introducer is now completely removed and the silicone catheter connected with the easy lock system. The catheter insertion distance is adjusted according to the defined measurement. The position of the silicone catheter in the inferior vena cava is verified by X-ray. The catheter is secured on the abdomen with steri strips and the catheter hub placed on sterile gauze. The parenteral infusion line is connected to the easy lock system under sterile conditions. Catheter and hub are covered with opsite. The maintenance technique of the catheter is identical to the percutaneously inserted silicone catheters. The catheter position, verified by X-rays at insertion, will be documented again 1 or 2 days later by echocardiogram. This will be repeated before removal of the catheter in order to exclude thrombosis. When the catheter is removed, the baby receives oral glucose as comfort care. A bacteriological swab of the umbilicus and culture of the catheter tip are performed. The umbilicus has a normal aspect.
We evaluated the complications of all silicone catheters over a 3-year period. 352 files were analyzed. 13 babies died, but none of the causes of death was related to the catheters. The 339 remaining babies were divided into 4 groups. The 2 first groups are the infants with 1 catheter, 1 umbilical catheter, the USVC group, and those with 1 percutaneous catheter, the PSVC group. Birth weights of both groups are comparable. Gestational age in the PSVC group is slightly different, although the median is the same, but the number of babies above 37 weeks was higher in this group. The number of babies below 1,000 grams was similar in both groups. Congenital anomaly was higher in the PSVC group, but this was a selection bias because the infants with abdominal surgery could of course not receive an umbilical catheter. The 3rd and the 4th group of the infants are those infants who received several catheters. USVC, PSVC infants were those who received first an umbilical catheter followed by a percutaneous catheter. PSVC, PSVC group were those infants who only had several percutaneous catheters. Those 2 groups are much smaller than the previous ones, and absolutely comparable in terms of birth weight, gestational age, very low birth weight below 1,000 grams, and the number of congenital anomalies. The last column shows you the total number of patients. The USVC being those who have received at least 1 umbilical catheter, and the PSVC group those who never had an umbilical catheter. Again, birth weight is slightly higher in the PSVC group, gestational age and very low birth weight are similar, and the congenital anomalies are higher in the PSVC group. The next table shows you the catheter use for newborns who had 1 catheter. The infants with the USVC had their catheter inserted earlier compared to the infants with the PSVC. The duration of catheterization and the percentage of elective withdrawal was similar in both groups. As you can see, elective withdrawal was very high in those categories. The next table shows you the catheter use for newborns who had more than 1 catheter. Both groups are much smaller than those who had 1 catheter. Catheter insertion for first catheter, number of catheters, duration of catheterization, and elective withdrawal was absolutely similar in both groups. The next 2 tables shows you the catheter complications. In the first table you see thrombosis and mechanical obstruction. Thrombosis was not very frequent, occurred only in the USVC group, but was not significantly different from the PSVC groups. Mechanical obstruction was very rare in the USVC group, but occurred significantly more often in group 4, which was group PSVC plus PSVC. The following table shows you the catheter complications related to infection. Catheter-related sepsis was only 2.5% in the total USVC group and 3.5% in the PSVC group, but none of the sepsis rates was statistically significantly different among groups. The probably related catheter sepsis was also very rare and not significantly different whether it was a USVC or a PSVC patient. The last table shows you the catheter-related complications in our study compared to those reported in the major studies of the literature. As you can see, the percentage of babies who had no complication in our study was rather favorable. The catheter-related sepsis rate was comparable, as was thrombosis and mechanical complications. No tamponade occurred in most of the studies. Silicone catheter complications are rare and similar, whether inserted transumbilically or percutaneously. The advantages of the umbilical silicone venous catheter are the following. The technique is easy, painless, comfortable, and has a vein-sparing effect.